Hi, this is Andrea Kane, and I'm here with HIT 340 Comparative Records. This is the second lecture for week 11. We are on chapter 13 for hospice. If you're looking at your syllabus, we are focusing on unit objectives 9.7.1 through 9.7.7. And so let's move forward. If you have your textbook out and want to be following along with me, you will want to turn to page 478. According to our book, we are learning the following about hospice. We're going to talk about criteria that has to be met for a patient to enter hospice care. We'll define the term hospice. We'll compare and contrast hospice care and traditional acute care. We'll talk about hospice facilities versus hospice beds in hospitals versus hospice care in skilled nursing facilities versus hospice care at home, among other things. We will talk about participants and their role because hospice is very much an interdisciplinary group that provides hospice care not only to patients but also to their families and caregivers. We will go through the 4 reimbursement levels of hospice care, including routine home care, respite care, general or acute inpatient care, and continuous care. We will talk about documentation requirements. What do we have to have? Both in the hospital setting as well as in the facility setting as well as in the home and other settings. We'll relate the use of hospice benefit periods to the associated documentation requirements, discuss the capture of clinical visit information to track the cost of hospice care, talk about Medicare COPs relating to hospice care, and we will, hospice care probably in the hospital setting, I would say. And then quality assessment, performance improvement in hospice settings, as well as bereavement care and documentation following the death of the hospice patient, because hospice really goes all the way through and even slightly after the patient has passed away. So what is hospice? Your book talks about how the roots of hospice can be traced along the same timeline as the history and development of the hospital, and that it's a French word and it is a place in which a guest was received. And in 1967, in England, London specifically, a lady was caring for dying patients and recognized and developed it as a philosophy and practice. And since then, it has just really taken off. Hospice care is different than palliative care. You may have heard of palliative care, and we're going to talk about both. Hospice is defined as a facility or a program to provide a caring environment to meet the physical and emotional needs of terminally ill patients and their families and significant others. And that is hospice. Palliative care, on the other hand, is clinical measures taken to reduce the intensity of disease symptoms rather than provide a cure for the disease. Now, hospice uses palliative care, but hospice is different. Palliative care can be used on patients who are not in hospice, so make sure that you know that difference. And the top of page 479, one of the things that they do is talk about the settings that hospice care is provided in. And I'm going to stop and go back before I move on to this slide, because they dovetail together. So at the top of page 479, majority of hospice programs provide patient care in the patient's place of residence, which may include the patient's home, a relative or friend's home, a nursing home, or a senior citizen complex like a retirement living center, assisted living, apartment, those types of things. So wherever the patient is, a lot of hospice programs provide care there, sort of like a home health care agency, but different. Hospice care is also provided in inpatient hospital units as well as in skilled nursing facilities or nursing homes. The hospice contracts with either the hospital or the nursing home, and they can establish units or wings, or they can have a contract that the patient stays in their same bed, their same hospital bed or same skilled nursing facility bed. It's simply that the care changes from being inpatient or skilled nursing facility care to being hospice care. Then there's standalone hospice, and this has become more popular to have an actual hospice house or hospice facility in a community. And those are where the hospice owns their own place, and patients come into the hospice usually within a week or two of passing away. They're not a hospital, they're not a nursing home. They're similar in that they use hospital beds and they provide some types of care, but they're really they're different in many ways as well. I have experiences with all of these settings from an HIM perspective, so I can speak to that a little bit. So we kind of covered this. Hospice, one of the things you need to know about hospice is that the care for hospice is when life expectancy is 6 months or less. That is the single biggest thing you'll need to know about hospice, is that life expectancy has to be 6 months or less. And then I talked a little bit about the history. Patients who are terminally ill typically receive palliative care as opposed to curative therapy. And as I talked about with palliative care, you don't have to be terminally ill to have palliative care. You may have a chronic disease condition that you choose to have treated with palliative care. That does not mean you have decided to pursue hospice care, but hospice care uses palliative care. They don't try anything curative. And again, your life expectancy has to be 6 months or less based on the physician's clinical judgment in order to qualify for hospice. Another thing that's different about hospice, other than the fact that patients are terminally ill, is that the unit of care is not just the patient. It's the patient and the family, or patient and their loved ones, or patient and those who are around them. Another really cool part about hospice is that they use an interdisciplinary team. You hope all of healthcare does as well, and they do to one extent or another, but somehow it seems a lot more evident in hospice care. If you've ever been around a hospice facility or a hospice organization, they're really all about teamwork. And you see that in a lot of what's happening in the home. They like to include pastoral or other counselors. They have volunteers. They have pharmacists, dietitians, just an enormous amount of people that are there for the patient and their family, or the patient and whoever else is part of their group, their unit. Primary caregivers of terminally ill patients are usually family or friends, and they provide ongoing care to the patient when hospice personnel is not present in the residence. My one personal experience with hospice had to do with my grandmother, and now this was back in the early 90s, so much has changed since then, and I've seen it since then from a healthcare perspective, an HIM perspective, rather than a personal or family perspective. But how it works then as well as now is that they meet with the patient, and they meet with the patient and family, and they meet with the family. And they, after they've assessed the patient and identified what their terminally ill status is, they determine the frequency of visits needed. And it may be that you start out with hospice, and the hospice nurse comes and visits once every 2 to 3 weeks, or even once every 3 to 4 weeks. As the illness progresses, they start coming more frequently to check on things. And so you may have that nurse coming in 3 times a week. And when it gets close to the end, you may see that nurse there every 6 to 8 hours. Or they may come and they may choose to stay. And that And the rest of the hospice team are that way as well. At the beginning, everyone is involved because they want to make sure that they know what's happening and what is going on, that the patient and family are well informed, that they have a chance to be a part of planning what's going to happen next. They're offered services of counseling and maybe a pastoral visit or some of the other things to make sure. So there's an intensity of service there at the beginning when hospice is brought in. Then as the illness progresses, it adjusts with the dying process. So as the patient gets closer and closer to dying, again, hospice services and hospice visits and hospice personnel availability may ramp up. At the end, it may be that you do have a hospice person there when the patient passes. You may also choose not to. That may be a family decision, that maybe you have a family member who is a nurse, who can be there and knows the steps to take when their loved one passes. That happened to be the case for my grandmother because my mom's a nurse. And so she stayed with my grandmother pretty much constantly the last several weeks of her life. Hospices have to have a state license. So that means they are licensed by their state. Each state has requirements. Although there are Medicare conditions of participation, COPs, for hospices, they can be deemed status. So you can have Joint Commission or Community Health Accreditation Program or Accreditation Commission for Healthcare, Inc. Any of those come in and do deem status. Just depends on what the hospice organization decides to go with. There is a National Hospice and Palliative Care Organization, NHPCO. They have standards. They do not survey, but they have standards and recommendations and all sorts of resources for hospice agencies. So the first thing that has to happen is you have to have certification. The patient has to have a terminal illness that is certified by an attending physician as well as the hospice medical director. And most hospices have to have a medical director. They don't always examine the patient because if the attending physician is there and they are documenting it and they are ordering the hospice care and certifying it, the hospice medical director typically kind of rubber stamps that. But if not, they're heavily involved. And the medical director is always overseeing the care. And sometimes the hospice medical director, as well as the attending physician, if the attending physician is a primary care physician, they both may make visits to the home, to the patient, or to the nursing facility or wherever. It just really depends. The patient has to elect hospice care. It has to be patient choice. It's not something that you can say automatically, oh, you've got a terminal illness, so therefore you will have hospice care. That is not the case. It's always elected. It's always voluntary. And the patient says, I understand my disease is terminal or my illness is terminal, and I want to waive my standard Medicare coverage and choose hospice care. Patients can revoke that. They can get into hospice care and then decide, ooh, I really do want curative care instead of palliative care, and they can revoke it and go back to having standard Medicare coverage. It's rare, but it does happen. They can change their designated hospice. They can decide, okay, typically in most communities there's one hospice organization, but if you're in a very large community, or a large city, you may have multiple hospice choices. You may start out with a particular hospice organization. For example, you may have them caring for you in your home and then decide that you really want to be in a hospice house. But the hospice organization that has a hospice house in your area is different. So you can transfer from one hospice to another. And let's see, we are now, where are we at? in your book. I've lost my place. My bad. All right, so we are up to page 486. All right, contracting with other facilities for Medicare benefit and regulation, you have to have a written agreement. That includes sharing copies of clinical records. Some hospice organizations still have paper records. Many do, in fact. Some use a hybrid system, and others have found ways to be able to purchase electronic record systems, but those are not the most common. So they have to be able to share copies of clinical records, whether that's electronically or by paper. You have to have a plan of care. Hospice volunteers, their hours have to be equal to at least 5% of total patient care hours of paid staff. This is a unique regulation in the conditions of participation. The COPs want to see that there are hospice volunteers. So when you look at administrative and patient care activities, those have to be 5% of the total patient care hours of paid employees and contract staff in patient care. Seems strange, I know, because volunteer staff don't have to be clinically oriented. They can do other things, but there needs to be, the number of volunteer hours have to be captured, and what those volunteer hours are made up of, yes, has to be captured. And you have to be able to prove that. And then clinical records. You always have clinical records. So you have comprehensive assessments, a plan of care. You have signed copies of patient rights, hospital election, informed consent, responses to medications, treatments with related physician orders, outcomes measurement data, physician certification of recertification of terminal illness, and copies of advance directives. So you've got to have all of these things. All right, so certification requirements, you need 2 physicians to certify the patient is terminally ill with life expectancy of 6 months or less. And this is what I said. The patient has to be examined and certified, and that certification has to be signed off by the hospice physician. So typically it's the attending physician or primary care physician that starts this process and certifies it. But that certification has to be signed off by the hospice physician. Sometimes it happens the opposite way, that a patient elects to go into hospice without interacting with their physician, their primary care or attending physician, and they are examined and everything by the hospice physician. The certification starts that way, and then they send it to an attending physician or primary care physician for sign-off. But typically, it's usually the attending physician that starts it, but sometimes it's the other. Sometimes it happens that way in the hospital, that a patient's getting ready to be discharged home and they're terminally ill, and they decide, I want to elect hospice care. And so a lot of times that'll be coordinated in the hospital, where the hospice physician will come in, they'll evaluate the patient, they'll do the certification, and then they'll just have the attending physician sign off on it. So that's when I see most of that happening. But typically, if the patient's seen by their physician in the office, then it gets started by that physician and certified by the hospice. So that's the way I've seen it happen. And then assessment, interdisciplinary plan of care, and associated documentation, that's all required. Volunteer documentation, you've got to keep track of those hours and what they're doing, and so you can prove that 5%. And then if there's any inpatient care, that documentation. And then you need to make sure that you get all of the documentation at the close of care, and if there's any care or services provided to the family after the person has passed away, it's called bereavement, and you need all of that bereavement documentation for your record before you close it. So reimbursement. Let's see here. If you look at your book, We're up to page 491. Look at the bottom of page 491. All right, so there's levels of care. The first level of care, or the lowest level of care, is routine in the place of residence. Then there's respite care. This is where the primary caregiver needs a break. And so they provide care to the patient, hospice care, hospice respite care, to give that caregiver a break. That is one unique thing. That is different than home health care. Home health care doesn't really do that. This is unique to hospice. And then you have general or acute inpatient care. And what happens there is and this is the way I've seen it happen in the hospital setting, is you have a patient and they identify that the patient is now actively dying. And the patient and family finally get to the point where they say, okay, we accept that this is happening and we want to go ahead with hospice care. They then stop all the curative care activities. They bring in hospice staff and they utilize hospice order sets for pain control and symptom management. And that's where the patient's still in an inpatient hospital bed. Hospital nurses are still coming in and providing some care. You know, they're still hanging the IV bags with morphine or whatever else is being used for pain control. They're still doing all those things. But you've now got hospice staff coming in, and you've got the order set that it follows for pain control, symptom management, that type of thing. And then you've got continuous care that's predominantly nursing care, that's 8 hours out of every 24-hour period taking place in the patient's place of residence. And then you've also have the hospice house type thing. And in the hospice house, it's like general care, patient care, because you actually have a bed and the patient's in the bed, and you have nurses, just like you would in a hospital, that are coming in, checking on the patient, taking vital signs, hanging those IV bags of fluid and pain control meds, those types of things. So as you're looking at this, general or acute inpatient care, that also includes hospice house when a patient's actually in a hospice house facility. And then the continuous care is where you've got 8 hours, at least 8 hours in the 24-hour period that are at the patient's place of residence. Per diem payments are based on levels of care. They include all the services related to the hospice diagnosis. Physicians bill for their services separately, of course. Reimbursement stops at death, but bereavement services can continue for up to a year. So the family or whoever's in that patient's unit of care, even though the reimbursement stops at death, the hospice can continue to provide bereavement services. And hospice services at a contracted inpatient facility are also included in the per diem. So in that example that I gave, where you turn from receiving inpatient facility care, whether that's at a hospice house or a hospital, and you turn into getting that hospice care, whatever that is, that's also included in the per diem. Hospice benefit period, there are 2 90-day periods followed by 60-day periods, because remember, it can be up to 6 months. So how is information management involved? Well, we're talking data and information flow. Coding and classifications. You're using ICD-10 CM for diagnoses. And then obviously any procedures are all CPT or physician services, their visits, their E&M codes are all CPT. You need to make sure when you're coding that the reason for the limited life expectancy is coded, whatever diagnosis that is. And then because this is a non-inpatient setting, you want to be coding signs, symptoms, and complications. Hospitals have EHRs. So if a patient receives hospice care in a healthcare organization, they're going to be a part of an EHR. And clinicians use laptops, tablets, mobile technology. There is specific software that's been developed for hospice, and more hospice organizations are utilizing that because, again, think about hospice. These are caregivers that are going into the home. So they are taking laptops, they are using tablets, they are using mobile technology, and it's so much more helpful to be able to do that. So electronic health records, this should say in hospice care, are increasing. They're already there in hospitals, but in hospice care, that is definitely on the increase. So data sets, what are we collecting in terms of information with hospice patients? Obviously patient data, resource data, census data, donations, bereavement, and volunteers. All of that has to be captured. And we are now up to page 499 in your book. Wow, that moved quickly. All right, so quality indicators, because again, you're wanting to make sure that their pain is very well controlled. Measuring to assess performance and improving performance, having performance improvement projects where you can show benchmarking and improvement, and monitoring the results of what you're doing. Are your performance improvement activities demonstrating improvement? Are your processes being improved? And are you seeing outcomes positively impacted because of it? So that's all part of quality assessment performance improvement in the hospice setting, and that is so important. Also satisfaction surveys. Again, every healthcare setting uses patient satisfaction. They do those surveys to make sure that that piece is reflected in terms of quality. And then quality monitoring and HIM look at record content, compliance with regulations, and data quality and integrity. Utilization, again, appropriateness of hospice care. Medicare limitation of inpatient days to 20% of total, and level of care supported by documentation. Risk management and legal issues. Yes, there are those also in the hospice setting. Consents. You've got to have lots and lots of consents for all the different things that happen with these patients. There has to be a clear legal representative of the patient. This needs to be very clearly defined, because when you think about death and dying and that whole process in there, you need to know at what point someone becomes the legal representative of the patient, and who is that in the family. There's nothing worse than getting into a knockdown, drag-out family fight over who is the decision maker when the patient's no longer capable of making decisions, and that has to be documented. Regulations regarding disclosure of protected health information, because again, a lot of information is being gathered for research and quality, payment, all of that. How are you handling your PHI? Are patients aware of that? Are they getting a notice of privacy practices and signing it? Are they understanding the content? How are you protecting and securing PHI in your hospice? HIM people can be experts on documentation standards and accreditation requirements and Medicare COPs and all those great things. They can manage the data. They can be heavily involved in the QAPI committee and activities. Also HIPAA privacy and security. And really these are the same things that can be happening in the home health field as well that we studied just before this. Trends, increased scrutiny of hospice eligibility. Yes, there's increased pressure on providers to be very careful when they label the patient as being terminal or having a terminal illness, making sure that they really are within that 6-month window. There are decreasing lengths of stay for hospice because, again, as providers hold off deeming whether or not a patient is terminal, with advancements in care and technology, patients are waiting longer and longer and longer, and providers are as well, before saying, oh, we really have reached that terminal point, or we really have reached that point of admitting that what we're doing is not working and nothing is really else available to do this. So yes, there are decreasing length of stays when it comes to hospice care. The OIG's annual work plan now has a hospice section in it. There have been revisions to federal, state, and local regulations regarding hospices. That has been happening over the last 5 years, I would say. There has been an expansion of the palliative care specialty. Absolutely. I remember when we started having palliative care physicians as a specialty rotating through the hospital and being called as consultants in patient care for all different fields, cardiology, pulmonology, gastroenterology. There's a lot of stuff that they started utilizing palliative care physicians for. There's a huge demand for that now. And palliative care does not necessarily mean hospice. It just means that it may be used prior to hospice, and then once hospice starts, they only use palliative care. And then there's absolutely an increased use of EHRs, or electronic health information systems, in the field of hospice. It used to be all paper-based, except for what happened in the hospital. Now they're really veering to electronic because the vendors have made the hospice products affordable, and they've specialized them to hospice. So again, hospice is only running the systems that they need, and they're just more functional. So that's really helped with that. All right, so in summary, significant differences between hospice care and care in other settings because the focus is on palliative rather than curative care. There's a decreased impact of coding on reimbursement. When it comes to hospice, it's not so much the coding that drives it. It's really, you got to remember again, it's per diem, and it's really more about what's happening with the patient and these other factors that are in with reimbursement. So it's not so much coding. Coding needs to be accurate and needs to be submitted, but it's not so direct as it is in a hospital-based setting. There are a lot fewer volume of requests for information that you run into, a lot less ROI. Because for most patients, this is the end of the line. And there's not going to be a request for the information other than possibly from the payer. And it's a diversified role for HIM. I mean, there's so much that can be done that's, I don't want to say non-traditional, but expanded beyond the typical release of information, chart analysis, coding. There's more to it with hospice, a chance to really branch out and possibly get into credentialing and privileging, quality management, risk management, HIPAA privacy and security, a little bit more than what you can get in some of the other areas. So here's some web activities if you're interested. And don't forget to do the self-reviews in your book and review questions so that you're ready for your quiz, because you will have a quiz on chapters 12 and 13 this week. All right, take care, enjoy the beautiful weather, and I will see you next week. And next week, we are on chapters 14 and 15, which are dental and vet settings. How fun is that? So we'll talk dental offices and veterinary centers. Take care.